Heart failure, acutely decompensated Muhammad Durrani, DO, MS Eric P. Blazar, MD Kevin Kucharski, DO Basics Description. Acute decompensated heart failure, ADHF, is a rapid onset impairment of cardiac pump function, either structurally or functionally, resulting in inefficient perfusion. This leads to a wide variety of symptoms that are secondary to excessive fluid accumulation and reduction in cardiac output. ADHF can be a new diagnosis or worsening of pre-existing chronic heart failure, HF. Epidemiology. Incidence. HF is a growing healthcare concern with regard to morbidity and mortality. HF hospitalization places a major strain on healthcare resources, and Medicare spends more to diagnose and treat HF than any other medical condition. HF is the most common cause of admission and readmission in the United States in those over the age of 65, responsible for more than 1 million annual hospitalizations. In 2012, the total cost of HF was $30.7 billion. By 2030, the total cost will increase 127% to $69.7 billion. The majority of costs, approximately 2/3, are attributed to the management of ADHF episodes. In the United States, there are 915,000 new cases annually. HF is the primary cause of greater than 55,000 deaths each year and a contributing factor in greater than 280,000 deaths. Greater than 1 million hospital discharges per year, unchanged from 2000 to 2010, and about half of people who have HF die within 5 years of diagnosis. 1 in 9 deaths has HF mentioned on the death certificate. The average 1-year mortality rates for first hospitalized ADHF patients range from 20%–30%. Prevalence. 6.5 million people age greater than 20 years in the United States carry an HF diagnosis. Prevalence is expected to increase 46% from 2012 to 2030, resulting in greater than 8.4 million cases in patients greater than 18 years of age. HF is primarily a disease of the elderly. 75% of hospital admissions for HF are in persons greater than 65 years of age. African Americans have the highest risk of developing HF, followed by Hispanics, whites, and Chinese Americans, which reflects differences in the prevalence of hypertension, HTN, diabetes mellitus, atrial fibrillation, obesity, and socioeconomic status. Etiology and pathophysiology. 2 potential pathophysiologic conditions lead to the clinical findings of HF, namely systolic and/or diastolic heart dysfunction. Systolic dysfunction, an inotropic abnormality, due to myocardial infarction, MI, or dilated or ischemic cardiomyopathy, CM, resulting in diminished systolic emptying, ejection fraction 45%, diastolic dysfunction, a compliance abnormality, due to hypertensive CM, in which ventricular relaxation is impaired, ejection fraction 45%, resulting in decreased filling. In an attempt to adopt a more pragmatic classification system, one that has been accepted by both the European and American HF guidelines, the terms HF with reduced midrange, or preserved LVEF, HFrEF, HFmrEF, and HFpEF, respectively, have been adopted recently. ADHF can result from the following conditions: myocardial disease, exacerbation of pre-existing chronic HF heralded by noncompliance or infection. Any of the following as causes of new HF or exacerbation of pre-existing chronic HF: coronary artery disease, CAD, MI, toxic damage, immune-mediated and inflammatory damage, infiltrative diseases, metabolic derangements, and genetic abnormalities. Abnormal loading conditions, HTN, valvular and myocardial structural defects, pericardial and endomyocardial pathologies, high output states, volume overload arrhythmias, atrial fibrillation, tachyarrhythmias, high-grade heart block, bradyarrhythmias. Genetics. Familial CM is a predisposition to the development of HF, rare. Risk factors: CAD and MI, RR 8.1 diabetes mellitus, RR 1.9 cigarette smoking, RR 1.6 valvular heart disease, RR 1.5 HTN, systemic or pulmonary, RR 1.4 dietary sodium intake, RR 1.4 obesity, RR 1.3 general prevention mortality reduction has been attributed to treating HF risk factors, see above, with the implementation of ACE inhibitors, beta blockers, coronary revascularization, implantable cardioverter defibrillators, and cardiac resynchronization strategies in patients. Some recommend B-type natriuretic peptide, BNP, screening in conjunction with guideline-directed management/therapies for at-risk populations to aid in the prevention of new-onset HF and to delay development of left ventricular, LV, dysfunction in existing HF. Commonly associated conditions. Dysrhythmia followed by pump failure is the leading cause of death in ADHF. Most patients have greater than 5 comorbidities, especially CAD, chronic kidney disease, and diabetes, and take greater than 5 medications. Cardiogenic shock diagnosis requires a multifaceted clinical approach with no gold standard diagnostic test, no single historical, physical exam, PE, ECG, or radiographic finding can rule out HF history. Patients typically have a history of HF, MI, uncontrolled HTN, and other risk factors mentioned above. Dyspnea on exertion and orthopnea are the only symptoms with high sensitivity but suffer from low specificity. Other symptoms include diminished exercise capacity, fatigue, general weakness, chest pain/discomfort if acute coronary syndrome, ACS, is present, paroxysmal nocturnal dyspnea, nocturnal non-productive cough, wheezing, especially nocturnal, in absence of a history of asthma or infection, cardiac asthma. Edema, abdominal bloating, ascites, anasarca, cyanosis, weight gain, greater than 2 kg/week. Physical exam S3 has the highest likelihood ratio, LR, in respect to PE with positive LR ranging from 1.6 to 13.0. No PE finding has sensitivity 70%. Peripheral pitting edema, cool extremities, cyanosis, hepatomegaly, hepatojugular reflux, cardiac murmur, hypotension, laterally displaced apical impulse lung exam, rales, crackles, and sometimes wheezing. Cheney-Stokes respirations. Differential diagnosis. Rule out life-threatening diagnoses first: pulmonary embolism, MI, tamponade, pneumothorax, acute respiratory distress syndrome, sepsis, chronic obstructive pulmonary disease, COPD, pneumonia, constrictive pericarditis, high output states, anemia, hyperthyroidism. Diagnostic tests and interpretation. Laboratory data are adjunctive and help with prognostication and clinical course. Initial tests, lab, imaging. First, assess blood pressure, BP, and other vital signs and rule out hemodynamic instability and signs of cardiogenic shock. ECG and cardiac troponins to evaluate for acute coronary syndrome, ACS. Note that elevated troponins are detected in the majority of HF patients, often without obvious myocardial ischemia. BUN, creatinine, electrolytes, liver function tests, TSH, new onset, glucose, and CBC. Routine ABG is not indicated. Transthoracic echocardiogram, recommended immediately in hemodynamically unstable ADHF patients and within 48 hours when cardiac structure and function are either not known or may have changed since previous studies. BNP N/or N-terminal fragment pro-BNP, NT-prob measurement of BNP or NT-prob is recommended in all patients with acute dyspnea and suspected ADHF to help in the differentiation of ADHF from non-cardiac causes. BNP 100 essentially will rule out HF with negative LR of 0.2 and sensitivity of 93.5%. BNP greater than 500 have a specificity of 89.8%. BNP 100 to 400 may indicate HF or may be due to a variety of cardiac and non-cardiac conditions. BNP has a relative increase in women, is lower with obesity, and is higher with renal dysfunction. NT-prob values greater than 450 pg/ml for people age 50 years, greater than 900 pg/ml ages 50 to 75 years, and greater than 1800 pg/ml. Ages greater than 75 years are highly suggestive of HF. Sensitivity 90%, specificity of 84%, in the correct clinical setting. 1b. Chest X-ray, to assess for pulmonary congestion and to detect other cardiac or non-cardiac diseases that may cause or contribute to the patient's symptoms: cardiomegaly, vascular redistribution, cephalization, with butterfly pattern of pulmonary edema, interstitial and alveolar edema, curly B lines, pleural effusions. Lung ultrasound, LUS emerging as a diagnostic tool for ADHF with a positive LUS defined by the presence of greater than 3 B lines in 2 bilateral lung zones, yielding a specificity of 92.7% and LR of 7.4. Follow-up tests and special considerations. Please see heart failure. Chronic diagnostic procedures / other cardiac catheterization may be considered when CAD is suspected. Pulmonary artery catheterization may be performed to guide therapy in severe cases with cardiogenic shock. Test interpretation. Cardiac pathology depends on the etiology of HF. Please refer to heart failure. Chronic treatment. The goal of treatment is to improve hemodynamics and organ perfusion, alleviate symptoms, limit cardiac and renal damage, restore oxygenation, and minimize hospital length of stay, as well as identify the etiology or precipitating factors. See heart failure, chronic as well. Medication alert. Contemporary therapies for ADHF remain suboptimal, and many therapies do not favorably impact morbidity or mortality. Diuretics are used initially in fluid overload ADHF, with nitrates added as needed. Once ADHF is stabilized, the guideline suggests an ACE inhibitor, ARB, or ARNI and beta blocker be started in patients with reduced systolic function. Use of new agent ivabradine has also been touted in select patients but has not been shown to reduce cardiovascular mortality. Avoid NSAIDs and COX-2 inhibitors. There are no Class IA drug recommendations for ADHF. First-line vasodilators. Consider in ADHF with systolic blood pressure SBP greater than 90 mmHg, and patients with hypertensive ADHF should get 4 vasodilators as initial therapy to reduce congestion. Use in chronic HF is not effective. 1b. Vasodilators lower ventricular filling pressure and systemic vascular resistance to indirectly improve cardiac function. 4-nitroglycerin may be of short-term benefit by decreasing preload and afterload by dilating peripheral capacitance and resistance vessels on vascular smooth musculature. 410 to 20 μg/min, increase up to 200 μg/min. 4-nitroprusside, administer with caution, start with 0.3 μg/kg/min, and increase up to 5.0 μg/kg/min. 4-loop diuretics recommended for all patients with ADHF and symptoms of fluid overload in hemodynamically stable patients, contraindicated if SBP 90 mmHg, severe hyponatremia, acidosis. Be cautious of electrolyte abnormalities if kidney disease is present. Diuresis should be instituted early in ADHF. Continuous infusion is no better than bolus, and high dose is not significantly better than low dose. Furosemide, Lasix. New onset ADHF patients should get boluses of 20 to 40 mg for. If on furosemide, Lasix, chronically, initial 4 dose should be equal or exceed chronic oral daily dose, 1.0-2.5 times home dose. Monitor for appropriate urine output. Thiazides in combination with loop diuretics may be useful if ineffective diuresis. Hydrochlorothiazide HCDZ 25 mg po. Thiazides in spironolactone or eplerenone, 25 to 50 mg po, may be used in combination with loop diuretics if excessive volume overload. Metolazone, Zeroxylin 2.5 to 20.0 mg/day po can be added as the second diuretic to loop diuretic in cases of ineffective diuresis and may be more effective than other thiazides in patients with renal insufficiency. Bilevel positive airway pressure, BiPAP/NPPV. NPPV decreases early mortality in ADHF. See additional therapies section. Second-line tolvaptan, an oral vasopressin antagonist, for severe hypervolemic hyponatremia refractory to water restriction and medical therapy inotropes, reserved for patients with severe systolic dysfunction occurring most often in hypotensive ADHF. Withdraw as hemodynamics improve due to increased short and medium-term mortality. ECG monitoring is required because they can induce ischemia and arrhythmias. Phosphodiesterase inhibitors, milrinone, inoxamone, decrease pulmonary resistance, may be used for patients on beta blockers but may increase medium-term mortality in CAD patients. Milrinone specifically produces ionotropic and vasodilatory effects without beta-adrenergic stimulation of the heart. Dobutamine infusion 2 to 20 μg/kg/min requires close BP monitoring. Avoid in cardiogenic shock or with tachyarrhythmias. Dobutamine works through a positive ionotropic effect along with stimulation of beta-adrenergic receptors in the heart. Low-dose dopamine infusion may be considered, 3 to 5 μg/kg/min. Levosimendan, calcium sensitizer, improves hemodynamic parameters but not survival compared to placebo while improving hemodynamic parameters and survival compared to dobutamine. Vasopressors, consider in patients with cardiogenic shock despite treatment with another inotrope. Norepinephrine 0.2 to 1.0 μg/kg/min compared with dopamine, 0.5 to 2.5 μg/kg/min, has fewer side effects and lower mortality. Epinephrine restricted to patients with persistent hypotension despite other agents. Neserutide, a BNP analog, is not recommended secondary to higher rates of hypotension, no benefit on death, or rehospitalization rates. Ultrafiltration renal replacement therapy, routine use of ultrafiltration is not recommended and should be used only in patients with refractory volume overload. Extracorporeal membrane oxygenation, ECMO veno-arterial ECMO for the sickest cohort of ADHF patients. ECMO has been used as a bridge to transplant or to long-term mechanical support. Additional therapies. Oxygen, begin treatment early, ideally titrate to an arterial oxygen saturation 92%, 90% if COPD. Cochrane review shows that 1 death can be avoided for every 14 ADHF patients treated with NPPV and 1 death for every 9 ADHF patients treated with CPAP. Avoid mechanical ventilation for patients with right HF if possible. Treat anemia with transfusion, conservative trigger hemoglobin 8, target hemoglobin 10. 4 iron replacement may help with New York Heart Association, NYHA, 2 and 3 patients. Avoid erythropoietin-stimulating agents. For patients with new-onset arrhythmias, consider pacing and/or antiarrhythmics. Please refer to heart failure, chronic for maintenance treatments. Surgery/other procedures. Heart valve surgery if valvular disease is responsible. PCI/CABG for patients with CAD/MI if applicable. Admission, inpatient, and nursing considerations. Admission criteria. Considerations, evidence of severely decompensated HF, including hypotension, worsening renal function, altered mental status, dyspnea at rest, decreased oxygenation, arrhythmias, electrolyte disturbances, associated comorbid conditions, as well as newly diagnosed HF. Consider observation unit stay for stable patients with pre-existing HF and the following: no acute interventions needed for comorbid condition, SBP greater than 120 mmHg, RR 32 bpm, BUN 40 mg/dl, creatinine 3.0 mg/dl, no evidence of ischemia or elevated troponins, and BNP 1000, N-type proBNP 5000. The clinical impression that the patient could be discharged in the next 24 hours. Inpatient, continuous pulse oxygen, daily weights, monitor input and output, fluid restriction, 2G sodium diet, echocardiogram if necessary, monitor for worsening HF, assess treatment response. 1.5 to 2.0 L/day fluid restriction may be useful to reduce congestive symptoms. Discharge criteria, improved symptoms, SBP normalized at 100 to 120 mm Hg, good urine output, serum sodium greater than 135 milliequivalent/L, HF outpatient education. Ongoing care follow-up recommendations: patient monitoring, rapid follow-up and multidisciplinary care to reduce hospitalization and mortality. Diet: reduce sodium, 2 grams, maintain cardiac or diabetic diet if these comorbidities are present. Patient education, monitoring and self-care, record daily weight, know how/when to use healthcare systems to increase the diuretic dose with weight gain or dyspnea. Medications: understand indications, dose, effects, and side effects of drugs. Adherence, value treatment plan maintenance. Alcohol, smoking, and drugs, abstinence recommended in alcohol-induced CM, smoking and illicit drug cessation. Exercise, understand the benefits of exercise. Prognosis: the ADHERE risk tree stratifies ADHF patients for inpatient mortality using SBP, BUN, and creatinine. S3 on PE correlates with poor prognosis. After diagnosis, 1-year survival 75%, 5-year survival 50%, 10-year survival 25%. Consider pre-discharge BNP to establish post-discharge prognosis in hospitalized patients. 1. C. Complications: arrhythmia, pulmonary edema, hyponatremia, death. Reference